know that the general guidelines for the head and neck squamous cell carcinoma, because we are interested, we know that this is the region where we can achieve the highest local regional control. And we are in the era today where we are not just interested for the anatomical, but also functional preservation. And the more or less the dictum for the head and neck squamous cell carcinomas is that for the early disease, we try to go for a single modality of treatment, that is surgery or radiation. And for the advanced disease, it is always a combined modality with surgery and radiation in most of the patients. And in few selected group of patients, it is chemoradiation. As Dr. Aditi was speaking, the paradigm shift in the chemotherapy, right from era of high dose chemotherapy to targeted therapy and to immunotherapy today, so is with the surgery, where we were so much radical before, but now we are conservative, and to an era where I'm again specifying that we go for an anatomical as well as functional preservation. And if I talk about my field of radiation, even when we started was very crude cobalt machines with wide field radiation, but now it has moved on to involved field and as well as more and more conformal radiation today. But not forgetting that head and neck squamous cell carcinoma is always a multidisciplinary team approach. And so I have a very esteemed group of panelists with me today. The key member, surgical oncologist with me today is Dr. Somesh Chandra sir, who is a director and head Department of Surgical Oncology in Sterling Cancer Hospital, Ahmedabad. I would request all my panelists to please keep yourselves unmute and to also do your video on so that we can see you all as well.
Hello,
With
everyone.
Hello. With us for the medical oncologist part, we have very two young and very dynamic medical oncologist, Dr. Abhishek Kakru, who is a consultant medical oncologist in Vedant Hospital, Ahmedabad, and Dr. Jay Dadania, who is a consultant medical oncologist in Sterling Cancer Hospital, Ahmedabad. In the radiation, we have very dear friends and very dynamic radiation oncologists with me today, Dr. Kinjal Jani, who is the director and head Department of Radiation Oncology at HCG, Ahmedabad. Dr. Pritanjali Singh, she is head of the department in AIMS Patna. Dr. Prapti Patel Desai, my dear friend, she's a radiation oncologist at SIMS Hospital, Ahmedabad. Dr. Rashi Agarwal, again a dear friend, she is a senior consultant radiation oncologist at Max Hospital, Delhi. And Dr. Samir Bhatan, who is again a radiation oncologist in HCG Cancer Hospital, Ahmedabad. Point of bringing Kinjal Bhai and Samir here is that they are heading to different units, so I want to see how they take these cases. But not forgetting again, we all key members are helpless without our radiologists and pathologists who really help us to diagnose the disease. So with me today is Dr. Deepal Bhesha, who is a consultant radiologist in Sterling Cancer Hospital, Ahmedabad, and Dr. Chetna Bhullar, who is a consultant pathologist in Sterling Cancer Hospital, Ahmedabad. With us also are many important key members, but my panelists will be here today for these cases. So not wasting much time, I straightforward go to the first case. He is a 48-year-old young male, no comorbidities, but history of smoking, 20-pack years, and history of chewing tobacco. He had a complaint of pain and irritation in throat for about 3 months and neck swelling since 2 months. Had a good performance status of PS1. Oral cavity had no enclaviglossia and no trismus. Even an ideal was almost normal. There was no gross disease found. The neck examination had around 4 centimeter lymph nodes seen at the level 2 and level 3, which was partially mobile. So my first question is to Dr. Somesh, sir, because sir, you are the one who will be seeing this patient first. With this clinical presentation, how would you like to investigate the patient?
Clearly, the throat needs to be examined. He has got complaints from the throat and level 2, 3 node, which indicates that there is likely to be something in the pharynx or larynx. So, my uh, common practice is to do a flexible laryngopharyngoscopy for these patients, which is done on an all-pushing basis. And if you find a lesion, you biopsy that, and you can accurately map out the tumor.
So regarding the imaging, is it any preference for you to go for a CT or MR, like for this case?
They are not necessarily mutually exclusive. So you may actually want to do both of them. Most of the time, you would start with a CT. If you want to assess more of soft tissues in the skull base or pharyngeal muscles, or maybe something to do with the thyroid cartilages, you would probably add MR to that.
And so what tempts you to make even a PET added into the diagnosis part?
So pharyngeal, especially hypopharyngeal tumors, locally advanced tumors T3, T4 have a high incidence of distant metastasis. Uh, almost up to 20-22%. So it makes sense to add that.
So with this clinical presentation, what I showed, would you advise a CT and a PET on day one only?
I guess you said that there is a 3 by 4 centimeter lymph node at level
Yes.
2. Okay. So we are dealing with N2 disease.
Mm-hmm.
The T stage is not known. Yes, a PET CT would be advisable. I mean, it's not mandatory. If you don't have a PET CT, it's not that you cannot manage these patients. But if you have, then it simplifies the workup to a great deal.
And a very stupid question to ask, sir. If you did an imaging, you did a PET also, and you found a clear disease at the hypopharynx, so you don't want to go for a scopy, and you just take a FNSC from the neck node. So would you be happy to stamp the diagnosis with that and start the treatment, or you would still like to go for a scopy and a biopsy?
Uh, so you want a stupid answer or you want a
No,
wise
I
answer?
want a wise answer from a wise man.
Okay, so the T stage needs to be determined anyway, and especially if you're looking at the hypopharynx, you need to do a very good endoscopic examination with magnification, and if preferably with NBI, you often get skip areas of mucosal lesions, which is very common, not or I would say not so uncommon in hypopharyngeal tumors, and if you have not addressed that, you have not seen that, then you could end up missing them on during your treatment, whether it's radiation or surgery. It would be a surgical surprise, and it would be a radiation miss.
So any other specific investigation, sir, or I would start with the imaging with Deepal Bhai?
Uh, the other investigation which we always do for such tumors, which can affect the swallowing, is assess the pulmonary function and the nutrition status of these patients. Uh, when if all of locally advanced tumors, local regionally advanced, would need radiation either as definitive treatment or adjuvant with surgery. So all the necessary precautions related to radiation, oral hygiene, and status of the teeth, and all those things obviously need to be addressed.
So this is the imaging of this patient. He was being advised for a CT and a PET CT on day one only. And Dr. Deepal Bhai is with us. So Deepal Bhai, can you please read these images for us?
Yeah. On PET CT images, there is FDG, avid enhancing lesion involving left AE fold and middle wall of left piriform fossa. The lesion is abutting left lamina of thyroid cartilage without invasion of the cartilage. There are few enlarged FDG avid lymph nodes at left level 2 and 3. The largest node shows internal necrotic areas and it abuts left sternocleidomastoid muscle.
So Deepal Bhai, can we add some more information with this node? Can we more go likely to the diagnosis part? Or this is what we can getting the information from the imaging?
No, from this image, we can say whether there is extra capsular spread or not. So in this case, there is no obvious perinodal fast trending or irregular margin of the node. So this is likely to be N2B disease.
Okay, so more or less, Deepal Bhai is already confirmed. It's a small primary, around about 1.5 centimeter at the aryepiglottic fold and piriform fossa, and even the PET CT confirmed as SV max 4.1 with a FDG avid node, central necrotic part around the SUV with max of 4.7. The lesion was compressing the left IJV, and there was a focally phased fat plane with the ICA. Even the scopy confirmed the growth, and the biopsy was moderately differentiated squamous cell carcinoma. So before I begin that how my esteemed panelists would like to treat this case, I would first like to have a poll from the audience. And the audience link where you are seeing these slides, you will see a button on the top of your screen where you can you can post your results. So for this presentation, a T1 case with a N2 neck node, how would you like to go? Would you like to start with neoadjuvant chemotherapy and then with response evaluation go with CTRT as option A, or you would go for upfront RTCT and then take for surgical salvage because the node likely would not regress completely, or would like to go for an upfront neck dissection first and then radiate the neck if it is positive, and take the case of the primary as well. So you can poll your results as A, B, C, and then we will have an idea what the house believes to treat this way in a pattern. Can we have the results? So there was 80% of the people who believed that we could directly start with chemo radiation in this case and then go for salvage surgery if required. Okay. So starting with my panelists again, Dr. Somesh sir, coming back to you. Would you like to do a upfront surgery, or you would go with the audience that yes, we would start with radiation chemo in this case? Sir, you have to unmute yourself.
For locoregionally advanced laryngopharyngeal cancers, if the option of laryngeal preservation surgery is not available, the standard of care is concurrent chemoradiation. In this patient, clearly, laryngeal preservation surgery is possible. TOLS is a very straightforward surgery for this patient combined with a neck dissection. So I won't do just a neck dissection. I would dissect the primary as a laryngeal preservation procedure, as a minimally invasive transoral procedure without disturbing the pharynx, and then radiate the patient. So that's an option which is as good as chemoradiation. Both the options obviously have their pros and cons, because a salvage following a concurrent chemoradiation is not a very pleasant exercise for the patient or for the surgeon.
So coming to Dr. Kinjal, radiation oncologist, do you agree with sir and address the patient first for surgery and then take for adjuvant radiation, or you would like to be the first treating doctor in this case?
So looking at the scenario, I would like to differ a bit with Somesh sir in this scenario, because for a locally advanced hypopharyngeal malignancies where it is a T1 T2 primary and N2 or N3. To be very honest with you, I don't agree with your or Deepal's decision that it's a N2 disease. It may be a N3B. It may be a node with a perinodal extension. So the point is, here we are talking about a small primary and a large node. So the scenario here can be, Dr. Abhishek would also agree with me that, we can, if you feel that, it's not a curable disease with chemoradiation, you can think of a neoadjuvant chemotherapy, because in a hypopharynx, you can definitely think about a NSCT followed by CTRT if you think it's a big node, right? And in a scenario where you feel that it's a curable with chemoradiation, you directly go for chemoradiation. So here, giving a larynx preservation surgery followed by chemoradiation is a bit too much for the patient. So I would feel either you go for a concurrent chemoradiation followed by salvage surgery for the neck dissection, or you go for a neoadjuvant chemotherapy, downstage the tumor and go for a chemoradiation. So I disagree with the primary treatment for the surgery. Okay, for the node it's fine, but I think Dr. Abhishek can take it from here, either NSCT or directly CTRT followed by something.
So why not C?
Yes, Abhishek.
Why not C?
Yeah, Abhishek, my surgeon says that if he would like to go for C, he would not just do only neck dissection, he would do a TORS also.
I would like to ask Somesh sir, why not C?
No point of TORS.
Primary is very small. Probably the
very small. Why do you want to do TORS? Exactly.
Exactly. May I pitch in? 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 Okay. So may I pitch in? If you look at radiation
and everything, but why not C?
If you talk about radiocurable cancers in the larynx and hypopharynx, the most radiocurable are glottic cancers. If you look at T1 glottic cancers, you still have a 10% failure rate at the primary site. Now, if you obviously hypopharynx has a higher failure rate. So you're talking about a T1, T2 supraglottic or pariform membranous pariform cancers, where you're at the primary side, post chemoradiation, expect a failure rate not less than 15%. Salvaging post concurrent chemoradiation, a hypopharyngeal cancer or a neck node is I think
Sir,
a
C.
hell of a
Sir,
job.
C. Option C.
Yeah, so I
C is
think
fine.
it's
C is
just
fine,
a
but
mental
not the
block.
surgery for the
It's
primary. C is fine.
either
Sir,
C is okay, but
so
not the
Sir,
surgery
I'm
for the
asking
primary.
you. I'm not opining. I'm asking you.
yeah, so that is what I'm saying. If you're doing a surgery for the neck, it's not a large neck. It's most likely an extranodal spread. It's not a more than 6 centimeters neck, which we are talking about. So if you're doing a surgery for the neck, you don't touch the lateral pharyngeal wall. Here, the lateral pharyngeal wall is clearly free. It's all on the medial side. It's better. I would prefer. I don't know. I mean, this is just a mental block because this was not being practiced. People were doing open surgeries. So you can take out the primary. It has no additional functional sequelae for the patient.
So
Sir,
now,
my
can I
sir, my
now
only
wait.
point, my only point here against what sir is saying is that you are getting rid of the primary. It's a T1 primary. You have got rid of the primary, but as it's a N2B or a N3 disease, anyways the patient would require adjuvant treatment in the form of radiotherapy with chemotherapy. Then why do you want to operate the primary side? Because it's a
Then why
radiotherapy
would
disease.
you want to operate the secondary site as well? So
I would not
in
want
my
to. I
books,
would not. I would
so
not
in
want
my
to. I would
books,
not want to operate.
in
I
my
would
books,
see.
exactly. So
It's
like I said up front, the standard of care, if a surgical laryngeal preservation is not possible, ASCO guidelines, then you would go for concurrent chemoradiation. Induction chemotherapy is a category 3 recommendation for these patients.
Now, can I say something? Can I say something, please? See, we
yes.
have now the point of why we are putting as a salvage surgery option here is we are not worried for the primary, we are worried for the neck node, right?
Yes.
So,
Yes.
so when we are thinking that maybe we need a salvage surgery only for the case of because our radiation would be very responsive for this piriform and the epiglottic, that to a very T1 lesion. So if the point of question comes, then probably even a neck dissection would be more than sufficient. Then go for adjuvant radiation chemo. That is what my philosophy says.
That is what I was saying.
No,
Yes.
So the point is, the point
The-
here is, if you are not confident to cure a T1 primary of hypopharynx with radiotherapy, and you want to do a surgery for a T1 hypopharynx, there is no point of doing a radical radiotherapy for any of the primary sites. You would just operate T1 nasopharynx, T1 base of tongue, T1 hypopharynx, T1 larynx. You would operate everything. So when you talk
yes,
about
you
T1
would.
hypopharynx,
I mean, we operate T1 larynx, we operate T1 base of tongue. These are all very standard of care treatments. You have to select your patients appropriately. I think
yeah.
it's not one treatment for all. I think we are into
Sir, you
that
are
age.
not going to
It
win
has to be
here.
an MDT.
Sir, you are not going to win this battle. There are 5 radiation oncologists and 1 surgeon.
the point is, we were trying to be giving less treatment to the patient. That was the reason behind it. Anyways, we'll move further because we have 3 cases to discuss.
What exactly would be done? What is the house saying?
So that we'll discuss again. We'll discuss again that then again that question for poll would come. Now, in case we decide that we are going for CTRT, because even the house initially was believing that 80% of the people were believing that we should go for upfront chemoradiation.
Yes.
Given this patient condition, he is not having. First of all, let me have a disclaimer here. He is not having trismus. It is for the sake that I wanted to show his dental status. I had his picture like this. So with this dental condition, I would like to ask Dr. Sameer, would you be ready enough to start radiation in this case?
Ma'am, anyways, at our institute, this is a protocol that whenever we are taking a head and neck patient for radiation, we subject that patient for pre-radiation dental prophylaxis. So, but looking at this clinical picture, I don't have any hesitation to start his chemo radiation. I will definitely start his. I would not like to delay his treatment. I would send him for pre-radiation prophylaxis. which will include scaling. If there is any loose or carious teeth, I would like to get them extracted. Otherwise, I would definitely start his radiation. I would not wait for anything.
Any radiation oncologist is differing from this?
Not exactly. Of course, we would send the patient for dental prophylaxis, and we would want extraction of any loose tooth, of course. But during radiation, I would always plan some sort of a fluoride gel or something, which my dental people will be giving to the patient. And,
Absolutely.
Yeah. So, Dr. Pritanjali, since you are here, could you just tell me in brief what would be the dose of radiation you would be giving in this patient?
So for this patient, if I'm starting radiation upfront, then I would like to give him maybe IMRT, and the dose that I would give would be 70 gray in 2 gray per fraction, 5 fractions a week for 6 to 7 weeks, of course, with concurrent chemotherapy. But if I can do also a sequential SIB or a sequential IMRT to this patient as well, in which, of course, according to the dose per fraction, if I'm giving SIB, then I would give 2.2 gray per fraction to the high risk area. And of course, the dose would be 66 gray at that region.
Any radiation oncologist who is not in a favor of SIB protocol?
So, Dr. Pooja, we are doing...
Ma'am, can I say something?
No, let Dr. Rashi finish first. Yes, Dr. Rashi.
Yeah, we are actually doing SIB in a different form. What we are doing, we are giving a GTV, a dose of 70 gray in 35 fraction. But we are giving a 60 gray 35 fraction to prophylactically. So we are not exactly increasing the dose of that gross disease, but we are decreasing from 1.6 gray per fraction to the prophylactic reason. That's how we are doing with concurrent chemo.
So my idea of putting this question of SIB here is this, as Dr. Rashi is trying to say, she would like to go for a SIB, but not increasing the dose per fraction of more than 2 gray for the reason. Dr. Kinjal, would you like to add something here?
So here, as Samir was trying to give an input from his side, I and Samir work at the same place, and we both have a different views on this. So when I do a SIB, I do a 2.1 gray for the GTV with the margin. So I would give like 69.3 gray into 33 fractions, and Samir would give 60 gray to the whole side, and then boost up the primary. So when you talk about a SIB, my protocol is 69.3 into 33 to the primary and the node, and then to the rest of the side, I might give 59.4 into 33. But Samir does it differently. You can ask Samir how he does it.
Yeah, so ma'am, I usually prefer a sequential boost. I prefer 2 gray per fraction conventional fractionation only. And in fact, last year only there was a publication, there was a meta-analysis which compared 7 trials, which compared SIB versus sequential. Frankly, there is no difference in terms of overall survival or toxicities or anything. There's no difference in survival. This I guess it depends on the personal experience. What I have experienced in past is that I have few patients who had cartilage necrosis in whom I tried SIB. So then onwards, I stopped using SIB, and now I'm using sequential only, and I'm quite comfortable in that. I don't see, even Saris is using SIB in his patients, and I have not seen any complications in his patient as well. But I guess I don't think so there's any literature or there's any evidence which supports SIB over sequential or sequential over SIB. So one more individual choice.
Yeah, Dr. Samir, one more thing that I have seen, when we plan sequential, what happens? Low dose increases.
Sorry, ma'am?
Low dose, when you plan after 60 gray, when you boost, then you have dose to uninvolved region.
Yes, ma'am.
So that's what happened. And when you plan SIB, the plan is very beautiful.
Yes, ma'am.
The same happens with breast. Earlier, we used to plan 60 gray in 25 fraction boost plus 50 gray in 25. With hyperfractionation, we have planned 14, 15, then 10 in 4. So somehow the plan, when you see SIB, it looks very nice. The dose is towards gross GTV region only, and low dose volume that is spreading in uninvolved area, that is less. But you are right. That's why we like.
I agree, ma'am. I'm sure. I guess a lot of things to understand.
Can I just ask Dr. Rashi one point that is she conversant with the dose 1.6 gray per fraction to the elective region? Is that okay? I mean, what are your results of your patients on SIB, or would you like to increase that to 1.8 gray per fraction at least?
Ma'am, yes, this question has been asked many times, and as Dr. Samir has already said, we have not seen any actually failure or local lesional control was not actually worse in these patients, and we are practicing from last 11 years.
Okay.
So our results are good, and actually all the studies, they also say 1.6 gray is good enough. We don't go below 1.6 gray. But you are right. Some people are worried about why we are going about 1.6 gray. It should be at least 1.8 gray. But when we see the plan is very good. So that's why, and we are not seeing any other thing. Dr. Kinjal, you can add anything?
Yeah, so I agree with you on this. We usually like to avoid giving 1.6 grade, to be very honest with you.
Yes.
But at the same time, even if you go for 1.6 grade, it is fine. But as rightly pointed out by Dr. Pitanjali, that we would like to keep it like 1.7 or 1.8 as the minimum, not beyond 1.7. But I have seen a few patients where we have done 1.6, but it is fine. It doesn't give any problems, to be very honest. Yeah.
So I would like to just put one point here, that my idea of putting a question of SIB over here was that, in fact, I'm a very SIB pro person, but I'm a little bit reluctant in these type of hypopharyngeal carcinomas doing a SIB, because as rightly said, the plants look very colorful, beautiful on the rose wash, color wash, but when the cartilage being near and you try to give a 2.2 gray per fraction, there the chances of cartilage necrosis are high. That makes me a little bit reluctant to use a SIP protocol in a hypopharyngeal carcinoma, especially when the cartilage is close by. That was the reason to highlight this point. Anyways,
Agreed.
we now stop the
Absolutely, ma'am. Absolutely. This is what I was about to say,
so
that
take it
when we are talking about head and neck in general, this is fine.
Dr. Samir, one person at a time. I apologize. We have 3 cases. Let it make it a little bit simpler, please. We now move into the concurrent chemotherapy. Dr. Samir, please apologize.
Yeah.
Dr. Abhishek, because there are more controversies than the radiation also. So, Dr. Abhishek, what is your preferred concurrent chemo schedule in this case?
Weekly one, which we are following. Although there is a trend toward the 3 weekly one, which is there's a slight advantage, but the toxicity seems to generally make me differ from using a 3 weekly dose. So I go with the standard weekly schedule of cisplatin.
What about the targeted drug? Abhishek, it is about targeted drug.
Let me first finish the dose. The dose is also a little bit complicated. So, Dr. Abhishek, you want to say because of the toxicity profile, you would like to go for a weekly cisplatin rather than a 3 weekly, right?
Right.
So, Dr. Jay, would you agree to that?
No, I would. Patient is quite young with good performance status, so we can proceed with the 3 weekly schedule of cisplatin. Because in majority of the trial, none of the trial that demonstrate superiority over 3 weekly cisplatin to any of the drug. Also, any of the trial doesn't show any non-inferiority versus 3 weekly cisplatin. So 3 weekly cisplatin is superior to all the drugs.
Okay, so let's have a poll on this about the efficacy of this weekly versus 3 weekly as well as the toxicity profile. So I put this second question for the audience. Which chemotherapy regimen has shown better outcomes in locally advanced squamous cell carcinoma of the head and neck? 30 milligram weekly cisplatin A, 40 milligram weekly cisplatin B, 100 milligram 3 weekly cisplatin C, or D, all show the same outcomes?
Pooja, Dr. Pooja, it is 30 milligram per meter square, yeah, only 30 mg?
It has to be meters.
Per meter square. Yes, per meter square.
Actually, one more thing, as far as I remember, some trial from TMH is there, which has used weekly cisplatin. Am I right? No.
Sorry, I didn't get you.
Some trial for weekly cisplatin is there from TMH.
That is a flat dose you're talking about?
Yeah, concurrent dose. And they have said that the Therapies trial.
Flat 30 is not sufficient. So let's not discuss about flat 30.
30 milligram per meter square.
That is 30 milligram per meter square.
Meter
not
square.
flat 30.
Meter square.
That is 30
Not
milligram
the
per
flat
meter
30.
square.
Yeah, not flat
trial.
30.
It's a study by Dr. Vinita Narone, I suppose, that 30 milligrams per meter square compared
30
with
milligrams per meter square.
100
Yeah,
milligrams per
yeah,
meter
Dr.
square.
Prashant, yes,
So
yes.
that did not
Yeah,
come as
so that's a 30 milligram per meter square, not 30 milligram stat. Like so,
No.
so
Yes.
the
per
is like
meter square.
yeah per meter square.
So we have the results, and the results say that 50% of the audience believe that the 300 milligram 3 weekly cisplatin is much better dose, and few people would like to go with 40 milligram per meter square weekly cisplatin. 30 milligram per meter square people are not finding this is adequate, and all show same outcomes as again 8.33%. So that is what is the audience believing over here. Okay, can I have the next question as well? Is the slide visible?
Yes.
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 So that's the third question for the audience here. Do you really observe lower adverse events in the weekly chemotherapy compared to 3 weekly chemotherapy? Option A, yes. Option B, no. And option C, same in both. You can put your opinions again. So the majority of the people, they believe yes for this question, that they say they observe lower adverse effects in the weekly chemotherapy compared to 3 weekly chemotherapy. And that is why I think Dr. Abhishek was trying to say that probably we would go for a weekly schedule. Okay, great. So not wasting much time.
I think
Yes.
Abhishek has a comment. Abhishek has a comment. He wants to say something.
Yes,
I
Dr. Abhishek.
just wanted to say I'm very clear in my mind that head and neck can be cured by a surgeon or a radiation oncologist. So generally don't try to be too smart with the concurrent chemo.
Nice.
So it generally what I feel is people find it very difficult to finish the radiation when I try to be over smart.
Good. Is it the slides again visible? I'm so sorry for this.
Yes, visible. Yes, visible.
Okay, fine. So I think Dr. Aditi had shown this slide, the Indian guideline recommendations for hypopharyngeal carcinoma. And if we see, the category 1 recommendation was here to go for concurrent chemoradiation plus nimotuzumab. So my question again to Dr. Abhishek, with this controversial topic that whether to go for weekly or 3 weekly, would you like to add a targeted therapy like Nemo in this case?
Of course, if given an option, definitely.
Okay. And what about you, Jebhai?
Yes, definitely, madam. If we are planning weekly cisplatin, then we can proceed with cisplatin with nimotuzumab. If cost is not the issue.
No, we are believing there is a day that nimotuzumab and cisplatin are available at the same price. And the Biocon would finish the talk right now.
Definitely. Then I will definitely go for that.
So there's a fifth question for the audience. Adding nimotuzumab to chemoradiotherapy in locally advanced commercial carcinoma of the head and neck improve the outcomes and can be considered as a standard of care. Kindly post your results. A, yes, B, no, or same in both.
So can I comment till you have
Yes,
the poll?
in between the free time, please, you're free to speak.
So I don't think we can take it as a standard of care. You can take it as a standard of care for India. Standard of care is a very difficult word to define because the level of evidence. I know there is evidence, but the level of evidence for using targeted with chemo for the other the rival drug is far better than what it is for this drug. So you can take it as a standard of care for India.
Yeah, so that was just the guidelines coming recently in the year 2020, which was speaking about the Indian consensus. Okay, not wasting much time again. So I think we principally agree for a weekly chemotherapy schedule with radiation for this case. Number one, is it okay for everyone?
No, Sumesh sir disagrees.
Sumesh sir, do you want to change your mind again, or we would like to stop here at the first case only?
Sir, you are muted. Sir,
What?
you are muted.
Change mind about what?
about your opinion. You are still for the TORS plus neck dissection, or you would say that let's go with the house?
No, uh, these decisions are not taken in isolation. These are all MDT decisions. And what I wanted to convey is that there are two equivalent options going by if you work according to evidence. Even if you look at the Indian guidelines, it says surgery and RT is an option. It doesn't say that surgery should only be neck dissection. So you cannot do half a surgery, right? So if you opt for surgery and radiation option, which is a category one recommendation, as good as concurrent chemoradiation, then you have to do surgery for both. You do not.
Okay, go ahead, sir.
If you are not operating, then you go for concurrent chemoradiation. That's my understanding.
So I take the conclusion from this case. Somesh sir very clearly said, I would go for an MDT. And I think with the MDT, what we are here sitting, we all believe majorly that we'll go for upfront CTRT. So we rest this case with the decision of going with an upfront CTRT. So we are not discussing anything further to this case and directly go to case number 2. So it's a 65-year-old young male with a good performance status. There is a history of tobacco smoking, 30-pack years. And he has left since 10 years because at that time probably he was diagnosed with asthma and he is on treatment for that, now pretty much comfortable. He observed a swelling in his right neck for about 3 to 4 months, which was initially small size, about our lemon, and now it is quite big. A primary examination of oral cavity in the ideal was within the normal limits. So these are the pictures. And if I move further with the PET CT, Dr. Deepal Bhai, can you read out these images for us?
Yeah. There is FDG avid large lobulated marginated lesion having internal necrotic areas on right side of neck. It is displacing submandibular gland anteriorly and adherent with it. The lesion is adherent with strap muscles of neck in the previous image, and pharyngolarynx is displaced towards the left side. So this is a large necrotic nodal mass with extra capsular fullness in the right vallecula as compared to left.
I have a question, Deepak.
Yeah, sir.
How do you differentiate between a cystic nodal metastasis and a nodal mass with internal necrosis?
So cystic nodal metastasis usually have relatively thin and smooth wall compared to necrosis, which is having irregular thick wall.
Okay, got it.
Okay. So I think this is what is the Deepal Bhai's comment and which is here seen. It was around about 8 centimeter mass, right from level 1B, 2, 3, and 4, and with a good amount of internal necrosis seen, displacing the vessels and the pharyngeal inlet. And there was a suspicious fullness in the right preepiglotic space and vallecula with the SUV of max 4.8. But I think we would take it as this not as significant because the triple endoscopy was negative. So the FNSC node was done and it was metastatic keratinizing squamous cell carcinoma. So I would now like Dr. Chetna, Madam, would you like to please comment what does this keratinizing mean and would it have any clinical implications for us?
See, this keratinizing, when we in an FNAC, when we see single cell keratinization, so that will be keratinizing squamous cell carcinoma. It implicates that this is a better differentiated tumor because in high oropharynx and base of tongue, usually we see poorly differentiated to moderately differentiated tumors.
Okay. So you want to say that this seems to be a good prognosis one? So before I again
better differentiated, yeah.
Better differentiated, sorry.
Yeah.
Yes. So before I again have a fight with amongst us, first of all, would like to have an opinion of the house. For this big neck node presentation, probably a stage 4B case, what would be your way of treating? Would you go for a neoadjuvant chemotherapy, then followed by response evaluation for radiation chemo and keep surgery as a salvage? Or you would go for option B, to have a neoadjuvant chemotherapy, then do a surgery and then address it for adjuvant radiation? Or you would do upfront CTRT, keeping surgery as a salvage? Or you think this node is big enough and probably we will give palliative radiation with best supportive care? You can put your result, post your results here. In free time, if anybody, Dr. Somesh sir, would you like to speak something?
Abhishek has a comment. Abhishek wants to comment.
Is keratinizing bad or good?
Keratinization is good because it is better differentiation.
No, what about the treating colleagues? I would like to ask the radiation guys, the surgeon,
So
is
the poorly
keratinizing good or
differentiated, they
bad?
usually tend to respond better. The poorly differentiated would, yes, Dr. Kinjal.
Yeah, so I would actually want Prapti to comment here because she has not spoken a single word right now. Let Prapti comment from the radiation oncology side. Let Prapti comment. Then I'll give my inputs. Prapti, go ahead, please.
Yes, sir. So I spoke, but it was mixed up many times.
Yeah, please go ahead.
Yes. So keratinizing is poorly differentiated, and definitely it is poor prognosis, but it poorly differentiated respond aggressively, betterly. So it respond to treatment good, but it has overall it is keratinizing is bad overall if we see in head and neck cancer.
That is what I had in my mind, that keratinizing is bad, non-keratinizing is better. The theory apart.
Yeah. So I think we got a result.
Around,
we got a result of the poll. Pooja, please go ahead.
Yeah, so around 40% believe that we should go for a neoadjuvant chemotherapy first, and few of them then had the other option as B and C, and with minimum as the palliative radiation. So is my slide again visible, or is
yeah,
not
visible, yes.
Yeah. So Somesh sir,
Yes.
would you like to do surgery in this case?
No, if you look at your own options, of the 4 options, 2 are neoadjuvant and 1 is palliative. So obviously, I think the consensus is that this patient is going to fare very poorly with such a large nodal metastasis, and there is very high chances of systemic failure also, even though neoadjuvant chemotherapy would not improve the overall survival or the rate of distant metastasis. But yes, I think this patient merits neoadjuvant chemotherapy, and then we can go further from that. 7.5 centimeters node. I'm not stupid enough to operate straight away.
So
maybe
I would at least we have a consensus over here from the surgeon. So now the medical oncologist, Dr. Abhishek, would you like to go for a neoadjuvant chemotherapy or an upfront CTRT?
No, I think you go for a chemotherapy. It's a big mass. I'm not very sure RT. In my mind, it looks palliative. I don't know how much we are going to cure it, but then if I had to try, he's 65. You should remember that he's 65. Asthma. There are a lot of problems we are going to face as far as chemo also goes.
I have another question.
If I had to do it, I would try and give chemo and then probably maybe reassess after 2 cycles for a surgery again.
Yeah, so I would just give my inputs here is like, the option A and B you can mix up, and you can say like you give neoadjuvant chemotherapy and then you reassess, how the patient responded. Then you can take it further from there. So, it can be a neoadjuvant chemotherapy, or if the patient is not responding, it can be a palliative chemotherapy.
If we look at guidelines, may I say something?
Yes, sir. Please go ahead.
Okay, so if you look at guidelines, if you're dealing with the metastasis of unknown origin, which primarily involves level 2 and 3, it is prudent to do HPV status for these patients from the nodal side. And if the P16 is negative, we should proceed to do an HPV DNA for these. Agreed that in our setting, all of them is going to come negative. But if we are talking about taking the right steps, I think this is the right thing to do.
What would be the implication in this case of doing an HPV?
Okay, so level 2 and 3 nodal metastasis with a MUO, the primary is usually in the tonsils or in the base tongue. Earlier, there was a practice. We had a practice of doing bilateral tonsillectomy for these patients, and you would find a primary in the tonsil. It is not about biopsying the tonsil. You have to excise the tonsils because it's in the tonsillar crypt or in the base tongue. So there are studies of TORS for the base tongue when you do a base tongue mucosectomy. So in these up to 20%, you will actually find the primary in these patients. And because the guidelines currently, most of the guidelines are written in the West, and they have 80% of their oropharyngeal are HPV. So that is how it appears in the guidelines that you must do an HPV for these patients.
So Dr. Jebhai, Dr. Abhishek wants to go for neogen chemotherapy. Would you agree with the same?
Yes, I would definitely agree with Abhishek Bhai. I would also go for neoadjuvant chemotherapy followed by response evaluation.
And what is your most common chemotherapy regimen you would like to use?
The patient is, I think, 65-year
Asthma.
with asthma. So I would definitely go for 2-drug chemotherapy. He would likely unable to tolerate 3-drug TPF regimen. So I would go for platinum with taxane in this patient.
So, Dr. Abhishek, you agree more or less with him?
I think we'll have a look at the patient. Age doesn't matter. Although he is 65 and asthmatic, maybe you can just have a look at the patient and decide.
Can I ask? Can I have a comment? Can I have a comment from both of you?
It's possible to. It's not difficult to give 2 cycles of TPF, but then age, asthma. So you'll have to have a look at the patient first. And
Can I have a comment?
how aggressive it has to be discussed with the relative. How aggressive they want to be, because as I said in the start, this ultimately would turn out to be palliative over the long run. I don't think we'll be able to cure this. I don't know where we'll.
Yeah, eight times out of 10, you would probably 3-4 months down the line, you would end up with some progression.
Exactly. Exactly.
So you could try.
Abhishek bhai, if I say that this patient is very fit enough, I know he is asthmatic, but I say, because you were trying to say that let's see the condition.
That is what I said. If the relatives are agreed, the patient is fit, TPF should be the drug of choice.
So would you like to add?
If the patient is fit, then I would also go for
the neogen chemotherapy setting.
Sorry?
Would you like to add the targeted therapy also in the neogen setting?
We do not have data for neoadjuvant, although the response means we do not have a consensus guideline. There is data, but we do not have a consensus guideline in using cetuximab or even nimotuzumab. But there is no consensus, but you can use it.
So can I have one question? One question to both the medical oncologists, that your choice of drug, TPF versus TIP. So like majority of the people use TPF, but when do you use TIP? When do you use TIP? And both of you can comment. I'm Abhishek and Jai, both.
Jai, go for it.
We would definitely recommend.
We do see a lot of medical
we are not using TIP.
That's why I asked this question. Actually,
Kinjal, is it because?
Understand.
Kinjal, do you want to imply that nodal disease responds better to ifosfamide?
So, sir, basically the reason why I asked this question is, a lot of medical oncologists are very fond of using ifosfamide instead of IFU. So I wanted the younger colleagues to know when to use TPF and when to use TIP. That's why I asked this question, to be very honest.
So I'll give you the answer. One of my teachers was the chairperson. He never taught me to use TIP.
No, nobody has taught us using TIP.
Yeah, but
So
I agree with you. I agree with you on this.
Can I ask a question?
Yes, Sameer.
Yeah. So my question is to Sumesh sir. So sir, suppose this patient has received chemotherapy, TPF 2 cycles. So one of the option was NACT followed by surgery. Other option was NACT followed by CTRT. So this patient has come to you after 2 cycles of neoadjuvant therapy. You can say more than partial response. The nodes has regressed. So what would be your approach, sir? Would you consider him for neck dissection first, or you would send him for chemoradiation, sir?
No, neck dissection first.
Okay. What about my radiation colleagues? Do you agree that the patient should still undergo neck dissection if there is a residual node? Or
Dr. Rashi, would you like to answer this?
Yeah, Dr. Sameer, you are saying patient had a good response.
Yeah.
Yes.
But there is a residual node, say 1 centimeter or something.
So I think 1 centimeter can be covered with radiation. If the
Okay.
node
So Sameer, we have now 2 patients. One has a 3 centimeter node, and one has a 1 centimeter node.
So say
you,
that 1 to 3
you can treat the 1 centimeter node, and I'll treat the 3 centimeter node.
So sir, is there a cutoff, or would you decide on something cutoff? If there's a residual node of this centimeter.
Okay. So if I have to, I'm not personally aware of any such guidelines.
Yes,
but if you extrapolate from neoadjuvant followed by concurrent chemoradiation protocols, then a response of 80% or more, more or less ensures that you will get 80% or more complete response with chemoradiation also. So between 50 and 80, I think it's prudent to add a local therapy up front, which is surgery.
Right.
Somesh sir, one question. In this case, or in any case like with such large cystic nodal metastasis, are you expecting response with chemo?
No, why you are asking me? You are giving the chemo.
Why did you give chemo?
No, I'll tell you why I'm asking.
I was not expecting anything because you see the three options. Of the three options, out of the three options, two were chemo, one was palliative treatment. So there was no option of any local treatment up front.
So I was asking.
So given the options, sir, would you consider neck dissection first?
Yes. So I was going to come to why again C. Yeah. The first case. What about the C option? So neck, no, not in this case. Neck dissection followed by CTRT.
Yeah.
No, there is. I am not aware of any literature which says that when you do surgery up front, you do half a surgery. This policy of doing this policy has been discussed. I think TMH has published a paper also on this on the issue of doing a surgery, just a neck dissection, and then following it up with radiation for the primary and the operated neck.
In this case, there is no primary. In this case, there is no primary, no?
No, right. So, no, in this case, this is an inoperable disease. I mean,
so this is inoperable, right?
Yeah. Neck, 7.5 centimeters with so much of soft tissue infiltration. This is a inoperable disease.
I'll tell you why. Neoadjuvant, I think we should do the neoadjuvant in this case, but many a times I find that these cystic nodal mets fail to respond as you desire to chemotherapy. So that is what
so that is what I asked. A cystic nodal metastasis could respond, but a nodal metastasis with a lot of necrosis would not because of anoxic areas.
Abhishek, I rightly mentioned earlier that this is a scenario where we are giving chemotherapy. Like don't name it as a neoadjuvant or palliative. Like we are giving chemotherapy 2 to 3 cycles. We are re-evaluating. If the patient responds, then patient becomes curative. If patient does not respond, the patient is palliative. So
so in med school,
you are giving a chemo upfront.
Absolutely.
When I was in med school, we used to make a differentiation between induction chemotherapy and neoadjuvant chemotherapy. So this was more like an induction. You were trying to induce the tumor to becoming a treatable tumor. Exactly. Otherwise, this is an untreatable tumor.
Untreatable. Exactly, sir. Rightly said, sir.
So, Prapti, I come to you with this case, given induction chemotherapy and the patient is responding, and it is now 2 centimeter lymph node. A very big miracle has happened. Now you would like to radiate this patient. So how would you go with your portals and dose?
So definitely I'll go with the concurrent chemo radiation. And in radiation, I would be planning my PTV volume GTV would be definitely the neck node, and the PTV volume will include the probable site of primary. That will include the nasopharynx, base of tongue, tonsils, larynx. That I will include in my PTV field. So definitely in this case, I will not go for SIB. I will straight ahead go with the 2 gray perfection involving bilateral neck and all the probable primary site, which I already explained. I will go up to 60 gray 30 fraction, and then I can boost the primary neck, which will respond probably after 60 gray, and then I will boost that side again for 6 to 10 gray.
So, Dr. Pritanjali, would you agree with Dr. Prapti radiating all the possible sites like nasopharynx as well? Or would you just be treating the oropharynx as a probable site of involvement? Dr. Pritanjali.
As a protocol, we are treating basically the probable sites, but in this case, I would maybe not leave alone the nasopharynx and just treat the oropharyngeal area, the base of tongue, the tonsillar region, and the neck, of course, and until 60 gray, and boost the residual neck, that is boost the area of the neck nodes till 70 gray approximately.
What about the contralateral side?
Contralateral, of course, we treat both of them, both of the sides till 60 gray, and of course, boost will be given till 70 gray to the ipsilateral side where the node was, the GTV primary.
So, Dr. Sameer and Dr. Kinjal, just a quick answer. Would you like to radiate the nasopharynx here?
No, I would not. I agree with Dr. Pritanjali. I will not be treating nasopharynx. If it is not a poorly differentiated or undifferentiated tumor, I'll not be treating a nasopharynx. I agree with
Not be
Dr.
treating
Pitanjali.
nasopharynx as well.
Yeah,
So-
I agree.
Yes. So the point is the undifferentiated or poorly differentiated would like to be tempted enough to be including the nasopharynx, but particularly this particular case, I think we can definitely spare the nasopharynx and just treat the oropharynx only. Okay. So again, Dr. Abhishek, you were not interested to use targeted therapy in the neogen setup because we didn't have any much data. But is there any data to use concurrent targeted therapy when we'll be starting chemoradiation after the patient has achieved response to induction chemotherapy?
I think that we have a consensus Indian guideline. We can use this nimotuzumab with cisplatin with the RT.
Maybe carboplatin. Maybe carboplatin.
Yeah, carboplatin with RT
Yeah.
and nimotuzumab.
Yeah.
Okay. So I'll not make much waste. Yeah. Okay. Now straight off to the case number 3. This is the last case. I think we have taken much time. So this is a young gentleman, 45-year-old male, non-tobacco, non-alcohol addiction, no comorbidities. He is presenting with difficulty in swallowing food since 6 months. And on a basic ideal examination, we find a growth in the base of the tongue extending to oral tongue and vallecula. These are his MR pictures. I'm sorry I could not get the CT images. Dr. Deepalbhai, would you please read out the images?
Yeah, these are the star and titubated images, axial images. There is very large hyperintense lesion involving posterior part of oral tongue on the right side, extending into base of tongue, lateral oropharyngeal wall. The lesion involves genioglossus and hyoglossus muscles and reaching on the left side. Posterolaterally, the lesion is and the lesion is also abutting submandibular gland.
Deepalbhai, from the radiological imaging, could you just guess whether the primary is coming from the oropharynx and going to oral, or it is reverse? Can we guess from this picture?
The epicenter of the lesion appears anterior as compared to oropharynx. So this could be, I think, from the tongue.
Dr. Somesh, sir, what would you say for this?
The epicenter lies more towards the oral cavity in this, I think.
So these are the findings. It's basically around 5 centimeter primary lesion involving the base of the tongue, lateral border, oral surface, quite extensive lesion involving the genioglossus muscle, genioid muscle, and of course it is going to the medial pterygoid muscle, and it's also going to the right suprahyoid pre-epiglottic space. Probably it's a very advanced. I would not go into the controversy whether it's an oral cavity going to oropharynx or oro going to oral cavity. The biopsy is squamous cell carcinoma. I just want to ask Dr. Chetna here. Looks to be a big primary, but N0. So first Somesh sir, would you be tempted to go for an HPV testing in this case because of the discordance of the primary and the neck node?
I mean, all oropharyngeal tumors should be tested for HPV. That goes without saying.
So Abhishek bhai, is the same practice in Vedant also to go for HPV in all cases, oropharyngeal cases?
Yes.
Dr.
Can I make a comment? I make a comment?
Yes.
Yeah. So our policy also, like rightly said by Somesh sir, we have any oropharynx cases, we go for HPV testing for any oropharynx. But here the scenario in HPV positive cases, usually there is a small primary and a big node. Here it is a different thing. Here there is no node. So I'm not too worried about the HPV because there are no nodes. In a HPV scenario, there are big nodes and smaller primary.
Even when we have large nodes, I mean, in our patients, practically all of them are HPV negative. But yes, we have to do that.
That is a routine thing. So we do HPV for all patients, all oropharynx. Yes, we have to do.
So Pritanjali, is this the same policy in your AIMS Patna also to go for HPV testing in all cases of oropharyngeal cases?
So we have put it in our protocol, and we have started doing it for all cases. Initially, it was not done for all the cases because of ICs and all were not available earlier. But now we have put it in our protocols.
Dr. Rashi, what about you? Max Delhi?
Yeah, here we are doing.
Okay. So now coming to you, Dr. Chetna. So how do we test for this HPV P16?
We do immunohistochemistry for P16, but the better protocol is to do immunohistochemistry as well as PCR. because there are a lot of false positives in P16. There are so many mechanisms which can upregulate P16, as well as there are so many false negatives, because most of the oral cancers in which frequently this P16 is lost. So better to increase the specificity, we should do P16 immunohistochemistry as well as HPV DNA PCR.
So, Dr. Chetna, all of these panelists were coming to a common consensus that for all the oropharyngeal, you should go for HPV testing. So, if all 100% cases are coming for you for HPV testing, what is your inference about the positivity rate of HPV16 in oropharyngeal carcinomas?
As far as I am aware, not in our scenario, not all the cases are being like P16 immunostaining is not being requested in each and every case. So what we see is
how many are positive?
hardly 5 to 7% positivity in our.
Same at our place. We have like 5 to 10% positivity for oropharynx, HPV positive. Yeah, so same at our place. 5 to 10%.
Ma'am, could I ask, if your cases are coming positive, then are you subjecting them to RT-PCR then? Or are you just following them up with IHC?
We are just doing immunohistochemistry. Okay. And if it is requested, HPV DNA PCR is done.
Yeah, so it happened. It so happened that in Ahmedabad, in most of the labs, we didn't have P16 testing available initially, but we were doing HPV DNA anyway because we are doing liquid cytology for pap smears and all. So we started off by doing HPV DNA for all the oropharyngeal. That was my practice at least, till P16 became widely available in Ahmedabad labs. So now we send for P16. I prefer to send for both if that's possible.
Okay. So, Dr. Jay, talking about so much of testing, does it really change in your practice of staging and management of these cases when if it is positive or negative?
Yes, madam. Staging would be changed after P16, depending upon the P16 status. But as of now, there is no difference in the management of the patient according to the HPV.
So with this case,
although there are trials ongoing for de-escalation therapy in HPV positive cases, but still there is no recommendation or consensus on.
If I'm not wrong, there's already a negative trial which has not supported de-escalating radiation or chemotherapy in these patients.
Yes. So the treatment part is not changed.
Deepal Bhai, one question to you. This MR finding did mention about the depth of invasion is 29 mm. Yeah. So have you seen that, or maybe we will be following it further, that this radiological finding is correlating finally with the histopath finding?
Yeah, there are so many literatures correlating radiological depth of invasion with the pathological depth of invasion, and there is a significant strong correlation between this and deep correlation with the pathological thickness.
So, sir.
Yes.
Do you really ask for every patient to be having this mention as on the imaging depth of invasion?
Yes, it's easy to ask.
Yes. All patients.
Yeah, all patients.
Depth for all patients. Any patients. Yes.
See, ideally, once we move into the pharynx and larynx, I would also like the radiologist to mention the tumor volume. Desirable, not essential.
Yeah. Okay, so with this patient, sir, would you go for surgery? Yes or no, and reasons for that?
I mean, what more reason do you need? You have three sites involved. You have oral cavity, oropharynx, and larynx. And the depth of invasion, I mean, it crosses midline. It involves the root of the tongue. So this is upfront, ab initio, and inoperable disease.
So, Kinjalbhai, we have a clearance from sir to go for radiation, definitive radiation therapy. And just as we were talking about, there are no, as of now, clear de-escalation protocols. It is only in the trial settings. So do you really go with the same fund of having the same radiation protocols if it was HPV positive or negative?
Yeah, so I absolutely agree with what Jai has said. Jai has nicely summarized that we don't change the radiation dose or the chemo protocols, even if it is HPV positive or negative. So I'm talking about 2021. Maybe 25, I might differ in my whatever I'm saying. But right now we follow the same protocol. Either we go for a sequential or we go for a simultaneous integrated boost. But we go with the same doses right now.
So Abhishek, is the chemo changing if it is HPV P16 positive or negative?
What was the age of this patient?
He was a young man, 40.
So yeah, that is what I remember. I would give him NACT first.
Wow. Wow.
So
yeah, it's a good choice.
It's a bad disease. It's a bad disease.
Yeah, to be very honest, yeah, NACT is a choice of, it can be one of the choices for a HPV positive.
He was 40, right?
There may be a CR after NACT.
He was 40.
Yeah, so he's right. Actually, he's right. It's an option.
So Dr. Jay, you would agree to that, or you would going for the CTRT upfront?
I would likely go with CTRT upfront.
Yeah, me too. CTRT.
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 Yeah, CTRT.
Yes, CTRT.
Okay.
I guess.
Okay.
What do you do if there is residual disease?
May I ask?
Yes.
Okay. Same patient with a large node, or N2 disease, or at least.
Yeah.
What would you do?
Definitely a neogen chemotherapy.
Okay.
So
Abhishek, you got the answer why they want chemoradiation.
Yeah. So there are no nodes. That's the reason, we would go for a CTRT. If there were nodes positive, they would respond fantastically with the neoadjuvant chemotherapy, and then, then we can do it like CTRT later on. But in this scenario,
40-year-old, 5-centimeter disease, blocking the entire tongue, reaching the midline. Come on, yaar. It's a bad disease. I am 100% sure your RT is not going to cure it.
Let us discuss.
Yeah. So again, same neck is clean, but this is a 65-year-old man.
40.
No. Now we have changed the age. So in that case, now would you go for upfront chemoradiation, 65 or maybe 70, 74?
You're asking
upfront concurrent chemoradiation or NACT?
Yes, Abhishek, to you.
You're asking me if he's fit, I would still try chemo.
And no, radiation oncology, concurrent 74-year.
Yeah, so
same disease.
A very nice question, sir. Very nice question, because as the age increases, giving a neoadjuvant chemotherapy, gives us a lot of problems when we are giving a concurrent CTRT after the NACT. So for a 65-year-old or 70-year-old, I'll be
pre-select radiation resistant cells.
Sorry?
You pre-select radiation resistant disease by giving NACT. Then you would radiate them.
Here we are talking for a HPV positive. Right now we are talking about an HPV positive. So which is a very sensitive tumor with chemo also.
No. In our setting, practically, we saw Chetan also said that hardly 5-7% HPV.
Yeah, exactly.
If it is HPV positive, I think you don't need to do anything other than concurrent chemoradiation.
Exactly.
So we have another last two questions for Paul. In cisplatin eligible locally advanced commercial carcinoma of the head and neck, is chemoradiation plus nimotuzumab a better treatment option than radiation plus other targeted therapies? So you can put your answers A, yes, B, no, and C, not sure.
So
Dr. Abhishek, what would you believe for this question? What is your answer for this?
We have no comparison to other targeted therapies. So answer is scientifically no.
Yeah.
So the previous question, I'll tell you what, there's no guideline, but what we do, and I do basically, is adult patient who I find are not good enough who I find would be incurable to even RT, we give weekly chemotherapy, weekly Pacli carbo. Keeping in mind the fitness of the patient, we keep increasing, and as they respond, we keep increasing the dose and schedule. And if they don't respond, I would refer it back to the radiation oncologist. But I've seen quite a few patients doing fantastically at elderly age with weekly chemo and responding.
Yeah, so I would like to also add here that Abhishek rightly said that when we get a patient who is not a fit candidate, like Somesh sir said, a 65, 70-year-old guy with a locally advanced head and neck tumors, and even if we give a paclicarbo, they respond fairly well, and then they take the chemoradiation much better. So sometimes you have to have a balance between the concurrent chemoradiation, NSCT followed by CTRT, or giving a 2-drug combination followed by CTRT. So, you have to choose your patients selectively. I agree with Abhishek here, yes.
So, Abhishek, to the previous poll, you said scientifically it would be a no, but the majority of believe is yes to that question, and 80% said yes. But now, if I give you a situation that he is confirmed HPV negative, so would you still be happy with CTRT alone, or you would like to add nimotuzumab here, or would you still believe in induction chemotherapy first, followed by radiation or chemoradiation? See?
Yeah.
So can we have the poll for this question as well? Meanwhile, Dr. Jebbai, would you agree to that? HPV
B.
negative, B.
I will go for B.
A or C. I would say A or C. I would say A or C.
Okay, so you are not.
A. I would say A.
A or C.
Just to make a
Yes,
point.
I would say A as well because
Yeah.
we can see the
Okay. By the time you take your poll, I suggest all of you to visit the IFROS site.
IFROS.
Yeah.
Yeah.
And there are certain videos there. I'm not talking about that there is a study or this thing. And there is a nice presentation from South Korea on induction CT followed by TORS for this patient.
Exactly, sir. I agree. Absolutely. It's a good choice. It's a good choice to go for a induction followed by TORS if possible. Yes.
So the audience changed their mind.
Yeah.
They came to see. Abhishek.
So I have to create my own options in this panel, you see.
I told you you are not going to win. There are 5 radiation guys.
No, but I'll win against the cancer. I will not win against the radiation oncologist.
There's only few times there are so many radiation oncologists are together. Maximum time, most of the surgeon and medical oncologists are there.
Abhishek bhai, you have to go tomorrow to Vedant, but I have to go to Sterling Cancer tomorrow.
So the point is, here is Abhishek can take care of all the medical oncologists and of the all the surgical and the radiation oncologists one side. Abhishek on the other side. Abhishek will win.
I told you, I am very clear in my mind that it is a disease for the surgeon and radiation guys. But
I agree with you.
There are some things in my mind, like tongue is bad. The larger the disease, I don't think the radiation or any surgeon could pull it off. So sometimes there are few things. I might be wrong, but there are few things in my mind. I'm very clear where I use neoadjuvant.
The same way, Abhishek, you have in your mind. I have also something in my mind. For me, indications for neoadjuvant chemotherapy are very clear. It has to be a N3 node, or there is some kind of airway obstruction. I would straight away send that patient for neoadjuvant. Otherwise, I would always prefer chemoradiation. Others may disagree, but this is what I feel.
And Dr. Abhishek, we would like to have you in Delhi.
अरे लेके आएंगे वो कश्मीर वाला बंदा है वो दिल्ली आएगा.
Okay, so I am skipping the last poll question because it is already 8:45. And before we wind up, I would just like to have a brief comment about the follow-up schedule from Dr. Somesh sir. What is your common schedule for follow-up in these type of locally advanced head and neck carcinoma cases?
Normally, the standard schedule is 2 monthly for 2 years and then 3 monthly for 3 years. But post-radiation evaluation is a difficult. And if we have doubts about how they would respond and not missing out on the salvage surgeries, because we have seen that in the RTOG 9011, the salvage surgeries which were done beyond 6 months, they had poorer outcomes. So if they have persistent disease, we would like to salvage them within 6 months as early as possible. So maybe for certain selected patients, I advise them monthly follow-up for initial 6 months, then 2 monthly for the next 18 months, and then 3 monthly for the next 3 years.
So I think there would not be any controversy for the follow-up. It was just a last comment. And I think the take-home message from this panel, interesting panel discussion, where we had a lot of controversies right from the case one. We still believe that MDT is still the treatment of choice to start with for locally advanced head and neck cancer cases, because there may be difference of opinion like we had in the case one and the case three primarily. But I think a sitting down together with all the consultants together can bring out a wise solution for each individual patient. And HPV testing, I think that's a very clean answer, that it is a must to be tested for all oropharyngeal cancers. Chemoradiation would be, the majority of the cases would go for chemoradiation with targeted therapy, preferably. So thank you, my esteemed panelists. We were almost half an hour going more as per the schedule time, but you all were very willing and happy to contribute. So any last comments from you before I say thank you and say that you can proceed for dinner at your own respective places?
Thank you, Dr. Pooja. That was nice discussion. Thank you so much.
Somesh sir, would you like to speak?
I thought